hospital hyperglycemia management, right? That's the whole topic which we're going to discuss in great detail. We'll discuss everything from definitions to management of hospital hyperglycemia in critically and non-critically ill patients. We'll also discuss a little bit about role of newer insulins in management of these conditions, and we'll also discuss about how to discharge these patients, what is the protocol for the same. So that's the agenda for today. So let's begin. I'm Dr. Om J Lakhani. I'm a consultant endocrinologist at Zydus Hospital in Ahmedabad. So management of hyperglycemia in a hospital setting is extremely challenging. There are a lot of challenges with this issue. It could be because of changes in diet. It could be there could be certain medications which the patient is taking. For example, the patient could be on steroids. The patient could be on ionotropes. The physiological factors also impact the glycemic outcome. So you will have acute illness. There will have physiological stress. Some of these patients would have renal dysfunction. So all these things contributes to the glycemic issues which we deal in patients who are hospitalized. Now, let's first understand the definition of hospital hyperglycemia. So any blood glucose reading more than 140 milligram per deciliter. So any random blood glucose reading more than 140 milligram per deciliter is considered to be hospital hyperglycemia. Now, there could be three situations, right? Either the patient is known to have diabetes mellitus, so patient is already having diabetes, or patient's HbA1c is more than 6.5%, but patient does not know that they have diabetes. So it's a newly diagnosed diabetes. Or it could be that the patient's HbA1c is less than 6.5%, but the blood glucose is more than 140, right? And this is what is known as stress hyperglycemia, right? So this is the first step in terms of understanding the definition. So any blood glucose more than 140 is considered to be hospital hyperglycemia. It could be in patients already having diabetes mellitus. It could be in patients who are having diabetes, but they are not knowing that they are having diabetes. This was very common during COVID period. Or it could be the patient was not having diabetes, but patient developed stress hyperglycemia, or in some cases because of glucocorticoids or steroids or inotropes, the patient developed hyperglycemia, right? So this is the definition as we saw earlier, right? Okay, now the next question which you have to understand, and next important concept you have to understand is what is the target, right? So, what should be the ideal blood glucose control, right? So we'll discuss in two situations. One is in ICU setting, in critically ill, and other is non-ICU setting. So what is the target in case of ICU and what is the target in case of non-ICU? So currently the recommended target in patients with ICU is 140 to 180 milligram per deciliter. Now I'll discuss this point a little bit in more detail. And in a non-ICU, in a non-critical ill patient, we tend to target the fasting blood sugar less than 140 and post-meal sugar to less than 180. Okay, so these are the targets that we generally keep in ICU and non-ICU setting. Now let's discuss a little bit about the target in ICU. So the history goes like this, that originally the first study which was done by Dr. Wendenberg from Netherlands, and what she did was she divided the patients into two categories, ICU patients. These were surgical ICU patients. So these patients who were on tight glucose control, and the other was on a more relaxed glucose control. And what she found was that patients with a tight glucose control, a range of 80 to 110, had a good blood sugar control compared to those patients who are having high blood glucose, right? So what she concluded is that tight glycemic control is very useful in patients with surgical ICU patients, where it reduces the hospital stay, reduces mortality and morbidity. Later on, they did another study which was called the NICE sugar trial. Now in this NICE sugar trial, what they did was they divided the patients into three groups. So one group was having tight control. The other group was having currently what we are doing, 140 to 180. And the third group was having lax control, right? So more relaxed control. So what they found was that the best outcome was in this group, right? In which the blood sugar was maintained between 140 to 180 in ICU setting. So those patients with a slightly tighter control, like Dr. Wendenberg said, In such situations, there were more risk of hypoglycemia and other complications. And again, those patients where the blood sugar was not tightly controlled had poor outcome. So they concluded that the blood glucose should be ranging between 140 to 180 milligram per deciliter. Now, interestingly, Dr. Vandenberg recently published another study which was published in New England Journal of Medicine, NEJM. It's a recent study, it's published in 2023, just a few months back. This is called the TGC FAST study. This is the name of the study. Now, in this, what they did was, they divided the patients into two groups. One was tight control, again 80 to 110, and the second group where what they did was that they put the patient on insulin only if the blood sugar was more than 215 milligram per deciliter, right? So, this was the two groups, and what they found, very interestingly, exactly opposite to what originally Dr. Vandenberg started, there was very little difference in the outcome in these two groups. That is, whether it was a tight control versus it was a more lax control. In both those groups, the primary outcome, that is mortality and morbidity or the duration of the ICU stay, did not make any difference. So, in future, we'll have a guideline, new updated guideline, where they'll say that perhaps I would say blood glucose between 140 to 215 milligram per deciliter is acceptable in ICU setting, right? So, in an ICU setting, this would be a more acceptable target. Definitely more than 215 with the earlier studies, you need to have a more tight control and bring it down to less than 215. So, this is the broad understanding of the current guidelines in terms of management in a critically ill patient. The non-critical ill patient, the targets can be more lenient, right? So, this is what this also is saying, right? So, in a ICU setting, this is the current recommendation. In a non-ICU setting, this is the current recommendation. It's exactly what I told you just a few minutes back. So, this is about the basics of understanding what is hyperglycemia in diabetic in a hospital setting and what were the targets. Now, let's look at the meat of this entire discussion, that is, how do you manage a patient in ICU or in non-ICU setting? How do you manage such patients for hyperglycemia, right? Now, what typically happens is, what I've seen, I've worked almost all my life in a hospital setting. I've been an endocrinologist for the current hospital since the last 7 years. And before that, I also worked in a tertiary care hospital in Delhi for almost 3 years. So, that's 10 years of my career. In the initial period of my career, I have spent in hospital setting, right? And all these hospitals, one of the major problems which you had to change every time you change the hospital was this bane of sliding scale insulin. Right now, you see all this. This is a bad idea. Somehow, this bad idea came into being, and this bad idea we are not able to get rid of. Right. So, the sliding scale insulin needs to go. Okay, this needs to be culled out of our system. I'll tell you exactly why sliding scale insulin is bad. Okay. So, what you need to understand is that when the blood glucose, right, is in, let's say there is 3 situations, right. So, situation 1 where blood glucose, so let's say this is 140 to 180, right. So, in situation 1, the blood glucose ranges between these levels, right. So, this is what you want in an ICU setting, right. Second situation is that let's say the blood glucose is high, but it is in a narrow range. Let's say it is between 180 to 220, right. Now, blood sugar is high, but it is on the little bit on the higher side, but it's still within a narrow range, right. Third situation is, let's take two extremes, 140 to 220. So, sometimes the blood sugar is less than 140, right. Sometimes the blood sugar is more than 220, right. This is how it's fluctuating. So, fluctuations are high. Which of these 3 patients, you need to tell me, does the best? Does this group do better? Does this group better? Or does this group do better? Right? So, the answer is this obviously does the best. This does the second best. So, even if the blood sugar is high, it is still doing better than this third situation, which does the worst. Right? Where the blood sugar goes up and down, goes up and down. And this is exactly what we are doing in sliding scale, right. So, what we are doing with sliding scale insulin is that It is a reactive form of diabetes management. So blood sugar, let's say, goes up. Let's say blood sugar is 230. Then we give insulin. Now blood sugar goes to 110, right? So what you have done, 230 for 110, right? Now, you do nothing because it's 110, you don't give any insulin, sugar goes up to again, let's say 250, right? So when the sugar goes up from this to this, there is development of reactive oxygen species, which produces damage. And when the blood sugar comes down from high to low, again, there is development of reactive oxygen species, which again does damage, right? So what you are doing is you are developing a roller coaster system where the sugar goes up, there is damage to the body, sugar goes down, there is damage again to the body. This is actually the worst case scenario. So sliding scale insulin actually does more harm to your patient. It is better to leave your patient alone with high sugars than to give sliding scale insulin, because sliding scale insulin will actually do more harm to your patients. And that's why this is something which has to be completely avoided. You need to maintain a steady state of blood glucose to maintain good outcomes in both surgical ICU, non-surgical ICU as well as non-ICU setting. So this is something which is very important, very fundamental, which all doctors should be aware, and you should all understand this as a fundamental concept. Okay, so let's see how do you manage hyperglycemia. So do not use sliding scale insulin, right? So what you need to do is you need to do two things. Generally, oral antidiabetics are not recommended. There are certain situations where oral antidiabetics are accepted, but most cases we have to use insulin. Now, when we use insulin in a ICU setting, in a critically ill patient, you use IV insulin, whereas in a non-critical ill patient, you use subcutaneous insulin. I think this is very simple and easy to understand, right? So these are standard guidelines. Okay. Now let's look at how do you treat a patient in a ICU setting, right? So in a critically ill setting or a ICU setting. So we already talked about the target. So the recommended target is 140 to 180. But now as I said, this is old now, because now with the new paper which has been published, you need to perhaps you can go up to 215, which is acceptable. In my opinion, I think 140 to 200 is an acceptable level. I generally do not want my patients to go more than 200, more than the renal threshold somehow. But again, if you look at the new paper from Greet-Wentenberg, I think, up to 215 is fine, right? So that's the idea, right? But this is the range where you should try and continue managing your patient in there. That doesn't mean if the patient does not have diabetes, you give glucose to increase the blood glucose to 140. No, that doesn't mean that. What it means is in a diabetic patient, or a patient with hypoglycemia, this is the target we should try and maintain in your diabetic or hyperglycemia patients. Okay, now let's see how do you manage a patient in a critical ill setting, right? So in a critical ill setting, you use IV insulin, okay, plus IV fluids. This is the standard treatment, right? Okay, now how do you do an IV insulin system, right? Now IV insulin system, what you do is we generally use 50 units of regular human insulin. So let's say Actrapid in 50 ml of normal saline, and then this is given through insulin infusion in a infusion pump, right? Now I'm going to show you later that instead of Actrapid, you can also consider using newer insulins like, right, Fiasp, right, or any other insulin which you can consider. So you can use a newer insulin also. It is perfectly acceptable to do that, right? So you use 50 units of insulin in 50 ml of normal saline through the infusion pump. Okay. Now what you do next, right? So now you take the patient's blood sugar. Let's say a patient gets admitted, random blood sugar, right? So let's say random blood sugar is 300, for example, right? So you divide this by 100, and this is you'll get 3 ml per hour. This is the rate of infusion which you should start. Okay. So this is what I do in my practice also. And after you have set the rate of infusion, after that you check the sugar generally 1 to 2 hourly. And again, depending on the the sugar value, you keep changing the rate of infusion. So let's say I had a patient who comes with blood sugar of 350. So I started at 3.5 ml per hour, and after let's say 1 hour the blood sugar is let's say 280. So I reduce the infusion to 2.8 ml per hour, right. So this is how you typically can do in terms of the blood sugar. This is the simplest way of doing it, right. This is very simple. You don't have to write any scale for the patient, for the nursing staff. You can just say that जो भी value है उसको 100 से divide करके that rate of infusion you give. Now typically we expect about 50 milligram per deciliter of reduction of insulin, reduction of blood sugar level per hour, right. So per hour you expect about 50 milligram per deciliter reduction. This is again not standard. This is a broadly accepted term. So if you don't have that rate of fall, then you can perhaps increase the scale. So what I typically do is I'll typically add 5. So let's 0.5. So let's say patient's blood sugar was 350, but after 1 hour it is just still 320. So instead of 3.2 I add 0.5. It is right 3.7, right. So that is how you typically can increase it. And again after let's say 1 hour it's still 310 only, okay. So the rate of fall is still slow. So 3.1 plus 1, so 4.1, right. So that is how you can keep increasing the uptake, right, of doing it. I hope this point is well understood, right. So this is like I already told you, right. So you can use there are some published protocols called Yale protocol. This is available as an app, but it used to be available as an app. It's not still available anymore. But we are actually developing an app for this also. So if those are interested, you can follow me on some of the social media channels like Twitter, or we have a YouTube channel called Endocrinology India. So you can follow us there. Whenever we make this app, we'll be happy to share that with you also. So this is the starting. This is the Yale infusion protocol. So you can use this. We are trying to develop a machine learning algorithm for this, so which could be even more useful. Okay, so I'll not go into details of the Yale protocol. This is a published protocol, but the methodology I told you works as well as the Yale protocol, right? So you can follow the same methodology in your practice as well. Okay. Now the second part of the management which we discussed was IV fluid. Okay. So what type of IV fluid generally we have to give? So what we generally do is, right, if the blood sugar is more than 250, or if it is less than 250, right, or if it is less than 200, right. So if it's more than 250, you give normal saline only, right. Don't give dextrose containing fluid. If it is between 200 to 250, right, then it is up to your clinical decision. If the patient is more vulnerable to develop hypoglycemia, then you give dextrose containing fluid, maybe 5% dextrose or DNS. If it's less than 200, definitely give DNS or 5% dextrose, right. So this is how you give the IV fluid. Okay. So this is the IV fluid you need to generally consider. Okay. Let's move ahead, right. So this is the Yale protocol, which like I said, Yale protocol is a little bit more complicated. So in such scenario, I would generally advise that instead of using the Yale protocol, you can use the protocol which I just discussed, which is much easier. And trust me, whether you use a complicated protocol or use a simple protocol, the outcome is generally the same. It doesn't really make too much of a difference. You can use more sophisticated protocols, or you can use a simpler protocol, right. Now your ICU patient, right, you admitted the patient, you have corrected the blood sugars are better now, blood sugars are stable. Now you want to switch from IV to subcutaneous insulin, right. So when and how do you switch from IV insulin to subcutaneous insulin? So if the blood sugar are stable, less than 180 for about 4 to 6 hours, right. Let's say the patient had diabetic ketoacidosis. Now normalization of the anion gap. This is very, very important, right. A lot of doctors who work with me now understand that, I always check you can use a venous blood glucose. You can use a VBG instead of, you don't need to do an ABG all the time. You can use a VBG and you can calculate the anion gap, right. I'm sure you are well aware about how to calculate the anion gap. Okay. So now good VBG machines already have this. So anion gap is basically sodium minus chloride plus bicarbonate, right. Or you can use sodium plus potassium, but some formulas don't use potassium. So you can just use sodium minus chloride plus bicarbonate. This is the anion gap, right. So if the anion gap is close, typically less than 10, the patient is generally considered to be out of diabetic ketoacidosis, right. So that is one. The other test, instead of using acetone, we use something called beta hydroxybutyrate, which is something we use. And another thing you have to remember is that when you are treating such patients, you need to take care of the potassium, right? This is very, very important because as you are giving IV insulin, the potassium levels comes down and the patient can develop hypokalemia. Okay, so these are some important clinical messages that we need to understand. Okay, so these are the broad understanding, right? So of normal anion gap. Patient is hemodynamically stable, patient is not on vasopressors, patient is on a stable nutrition, or patient is taking orally, and the stable IV drip is generally with low variability. In such cases, you can consider switching from IV to subcutaneous insulin in a ICU patient, and perhaps you are shifting the patient to the ward. This is how you generally do it. Okay, now how do you switch from IV insulin to subcutaneous insulin? So this is again a formula. I'm going to teach you how to use it. So what you do is you take the insulin given over the last 6 hours, right? So let's say the patient is on a insulin infusion rate of 1 ml per hour, right? So the last 6 hours the patient is taking 1 ml per hour. So last 6 hours patient has received, remember it is 50 units in 50 ml, right? So 1 unit in 1 ml, right? So if I am giving 1 ml per hour, that means I am giving 1 unit per hour, right? So in 6 hours we are given 6 units, right? So how much in 24 hours? 24 units naturally, right? So the total dose so you need to take just the last 6 hours, take the last 6 hours, multiply that by 4, right? So you'll get 24 units in this case, right? So the patient has received 24 units of insulin over the last 24 hours, right? Now what you do? Take 80% of this. So 80% into 24, right? So 80% of 24 is about 20 units. Okay. So again, take this 20 units. Now divide this into two parts, basal and bolus. Okay. So the basal dose here, okay, the basal dose will be 50%, which is 10 units. And the bolus dose will be the other 10 units. So typically the prescription what I'll typically give is something like this. Let's say insulin Tresiba 10 units at 7 p.m. and short acting insulin Fiasp, which you divide into 3 equal doses. So 4 units before breakfast, 3 units before lunch and 3 units before dinner. So more about equal dosing. Generally give a slightly higher dose in the morning, right? So this is the initial dosing which you'll do, and then we'll look at the next step about how to manage subcutaneous insulin. But this is typically what you do in your patient, right? So you transition from the subcutaneous IV insulin to subcutaneous insulin, exactly like I told you as a procedure. Okay. Now once you switch the patient to subcutaneous insulin, we typically monitor. How do you monitor the sugar? So typically we monitor before meals plus bedtime, right? So generally we monitor 4 times a day. Okay. Some cases you can monitor 6 times a day, but most cases we generally monitor 4 times a day. Okay. So this is how you typically monitor the patient. Okay. So let's now look ahead. A few things about diabetic emergencies. So just a few words of that. I'm not going to go into details. We can have a separate lecture on diabetic ketoacidosis, osmolar hyperglycemic state, and so on. So we can discuss this as a separate topic. But couple of points I'll tell you. So diabetic ketoacidosis, you need to be potassium needs to be very important, and you need to look at the anion gap, right? So these are the important points. For hyperosmolar hyperglycemic state, you need to be very careful about sodium. Okay, so I'm going to discuss these points separately. We can have a separate lecture on this in future, but the idea is these are some important points you need to be well aware, right? And we already talked about fluid replacement a little bit. So you need to be very aggressive in terms of fluid replacement in both these conditions, right? So fluid replacement has to be very, very important. The patient can develop severe dehydration. Okay. So yeah, so this is about, so again, we'll not go into detail about that. So now let's look at the other part of it, that is a patient who is in a non-ICU setting, right? Or the patient, so now we are going to see this, right? Subcutaneous insulin. So subcutaneous insulin you'll be using in 2 situations. Either the patient transition from ICU to ward, or the patient anyways was non-critically ill, right, and you shifted the patient directly, right. So here we already discussed the formula, how we will calculate the insulin dose and all that. But in a non-critical ill patient, how do you start the patient on an insulin regime? Okay, so we have a formula called Lakhani Kumar formula. Right. So this is a slightly complicated formula, right, where you have to use HbA1c, right. So you can read a paper which was published in Indian Journal of Endocrinology and Metabolism on this thing, right. So where we gave a formula which could be used as a starting formula for calculating the basal insulin dose, right. But again, to put it simply, a good way of doing it is take the patient's fasting blood sugar and divide by 10, and this will give you the basal dose. This is a simple formula to use, right. So this is based on the Hallman-Turner formula. Now Hallman-Turner formula basically was fasting blood sugar minus 50 divided by 10, but in a critical in a hospital setting, used to have a slight urgency in terms of the blood sugar control. So we use fasting divided by 10 directly instead of fasting minus 50 divided by 10, right. So let's say the patient's fasting blood sugar is 200, so 200 divided by 10 is going to be 20. So we will start the patient on 20 units of Tresiba, right. Now how much of bolus insulin to give? So basal dose is equal to total bolus dose. Okay. So you use the basal dose and total bolus dose. Okay. So what we do is, in this case again, right, the patient's basal dose is 20 units. So the formula, the prescription will be something like this. So you give Tresiba 20 units at 7 p.m. and you use FIASP 3 divided doses. So you use, let's say 6, right. So 8 and 6, 8 units before breakfast, 8 units before lunch, and 6 units before dinner, right. Now what is the next step? We typically ask the patient to monitor, or we ask the nursing staff to monitor blood sugar 4 times. That is before meal plus bedtime. Okay. Now here you have to understand how do you adjust the insulin dose. Now this is a very critical point, right? How do you adjust the dose of insulin, right? Okay. So here you need to do 2 things. So when you are in the round in the morning, at this point of time, you just adjust the dose of the basal insulin. Don't mess with the bolus dose at this point of time, right? So you just adjust the basal dose. Okay. So here what typically you should do is, you check the patient's fasting sugar, and the fasting sugar should be less than 140. So if the fasting sugar is more than 140, you increase the basal dose by generally 4 units. So let's say we started the patient on Tresiba 20 units, and next day morning the fasting blood sugar is 180, right, which is more than what we desire. So increase the Tresiba to 24 units, right. Then you look at the bolus dosing, right. So bolus dosing, you have 2 components. You have the fixed component plus additional dose. Okay. So you look at these 2 things, right. Now the fixed component is the dose which you fixed earlier, right. So that, let's say we had fixed it at 886, right. Now here you had already fixed the dose as 8 units. So this is the fixed component, right. And the additional dose which you will give will be the extra sugar. So let's say the pre-lunch sugar, you check the patient's pre-lunch, and pre-lunch blood sugar is 220. Okay, so it's high. Now you want the pre-lunch sugar to be less than 140. So let's put it as 140. So 220 minus 140, that's the extra dose of insulin which you require, right? So you take 60 plus 80. So 80 milligram per deciliter is the extra dose which you require, right? Now how do you correct for this, right? So you use a formula called insulin sensitivity factor. Okay, so ISF is 1700 divided by total dose of insulin. Okay, so in this patient, for example, right, the total dose of insulin is 20 plus 20, 40 units, right? So let's do the math here. 1610, so about 42, right? So the insulin sensitivity factor is about 42. So 1 unit of insulin reduces the blood sugar by to 42. Okay. So if you see this situation again, the patient's sugar is 220, we wanted it to be 140, so 80, right? So let's round that to 40. So 40 divided by 80, so you need 2 units extra. So you had planned to give 8 units, instead of that you give 10 units. Get it? So this is how you adjust the dose of the insulin further. Okay. Okay. Now, so this is how you construct the basal bolus regime, right? So what we gave, Tresiba was the basal, the fixed dose was the bolus dose, and then you gave a correctional dose of insulin, which was the extra blood sugar that you give, right? So I already talked about why sliding scale is wrong, and we already talked about calculation of insulin requirement, right? Okay, so this was the thing, right? So I'll give you some important messages at this point of time. First of all, right, you need to understand that hospital hyperglycemia is when blood glucose is more than 140. Now this could be pre-existing diabetes, newly diagnosed to have diabetes, or stress hyperglycemia. In a critically ill patient, you give IV insulin. In a non-critical ill patient, you give subcutaneous insulin. Okay, target is that in a ICU setting, it should be 140 to 180. Non-ICU setting, it should be fasting less than 140 and post-meal less than 180, right? So this is the broad summary of what we discussed. We also discussed the formulas of calculating.